And welcome to Bayou Time, and just a super important show that we're going to bring to you tonight. And joining me is Miss Phyllis Peoples, the CEO of Terrebonne General Health System. She'll be on the panel tonight, along with Dr. Ben Adams, a board-certified cardiothoracic anesthesiologist. That's a tough word. Try saying that real quick a few times. But this is just a super important show, because what we're going to try to do tonight is break down fact. There's a lot of misinformation out in the public. Man, if you read Facebook every night, you get all kind of different numbers. And I want to say this, because when we first started covering COVID a year and a half ago, we put our complete faith in these individuals on the desk tonight, along with all the support personnel, to save lives. We were in a panic. And as it progressed and we got a little more comfortable, we started taking that and changing the way we acted, or changing the way we thought. And I'm not saying all of that has been bad or good. It's a fact that we put a large responsibility on these local and regional hospitals to save us, when in fact they were finding something they had never seen before. So now we need to have a discussion. Where are we now? And I guess what I want to do is start off, because on this show, a year and a half ago, I get lost in time, both Phyllis and Dr. Adams told me, we're going to handle the COVID-19. We're going to handle this primary. It's going to do what it does. But somewhere down the road, we may see another version of it, which is where we are now. So I'm going to turn to Phyllis first. Correct me if I'm wrong. I'm not sure if I have the right wave or whatever, but third or fourth wave of this? What are y'all seeing about? What's the official thing? Are we in the fourth wave of this COVID?
You are in the fourth surge, high peak surge of it. And I think people, I guess, we've had a couple of conversations and we're trying to reach the public, Martin. But when you have a little bit of education on what we see every day, then when you hear the reports on TV, or you hear things on the radio, or you read things on Facebook, hopefully it gives you enough knowledge base to question what people are or aren't saying, so that you can do the right thing for yourself and for our community. Right now, the whole entire state, I just got off a call with the governor that all the hospital CEOs throughout the state are on once a week. And when you hear what's going on, not just in our region, this is not just a Bayou region problem. And that's what I think people may or may not understand. If you watch New Orleans, has no bed capacity. Lafayette area, Acadiana area, has no bed capacity. Baton Rouge has no bed capacity. Shreveport, Alexandria, us. And what that creates is that whenever we need to transfer patients to a higher level of care, we're able to take care of many, many things at Terrebonne. But at some times you may need some of that super expertise. There isn't bed capacity to be able to transfer people out. And so as the governor asks every single week, it's how to give resources. What are the limited supplies? People, we can get into some more detail, but one that came up today that we had not anticipated is there's a shortage on oxygen. Now, we didn't have that in the first one. So what does that do for your care model? It's a challenge. Yeah. So, that's kind of what we're seeing. Just if you want me to give an overview of what we look like right now at Terrebonne, and I'm not unique to the region. Mm-hmm. Thibodaux's seeing the same thing. We're seeing it at Chabert, St. Anne, Lady of the Sea, everybody in the Bayou region, and of course New Orleans, etc. Is right now we have close to 60 patients. I could give you an exact number, but by the time we tell you, it will be different, right? It will be different.
Very fluid.
So we have anywhere from 56 to 60 patients. That's our highest ever, even when we did COVID the first time, that are inpatient in our hospital. The Delta variant has it is so much more transmittable. It is much more contagious. People get it very easily. Some people will or won't get sick that they need hospital care for it, and some will. But we are finding the ones that will are coming in considerably ill. And Dr. Adams can get into the medical detail of that. We have ICU. We have ICU beds, but of those ICU beds, we have 20 and an overflow unit. We have over 10 to 12 that are already filled with COVID patients that may or may
What
not
do you
go
have,
home.
28 beds in your ICU, about?
I would say probably 24, because we're having to extend an overflow unit.
Okay, right.
And so we have, of those, we have 7 to 10 that will be intubated or on a ventilator.
Wow.
Now, again, Dr. Adams will explain a little more why we try never to get on a ventilator. So to us, that is a challenge, or on a severe BiPAP model. We have our COVID unit that has anywhere from 26 to 30 patients right now. Our ER has to be a holding area because we have no beds to be able to move to that ICU or to move onto the floor. And we are holding anywhere from 16 to 18. Now, in that math, I have a 28-bed ER. I went and made rounds this morning. My ER doc said I have less than 8 beds to care for people without COVID in. But they might be COVID. But if you come in with a heart attack, or you come in with a car wreck, or you come in with any surgical intervention or issue, I have just minimized my bed capacity to less than half for sure. Now that means that if you're not severely ill, you're going to wait in the ER. And our average wait times, when we triage, and we'll get into that detail, could be anywhere from 2 to 4 to 6 hours, 8, average of 10. So it is, what people don't realize is we are at capacity. Additionally, what people don't see is that even if we do get some beds that get available, our staff are all coming down with the virus, whether it's transmitted from home or the public or whatever. Where right now we have over 35 staff members who are out with COVID. Now, when you're out, you're 10 days out, right? If you feel better in 10 days. So now that means I got to wait for them to come back, which will be clinicians, nurses, respiratory therapists, anybody. It takes everybody to run our hospital. That's a lot to be short to be able to give care. And I know I dumped a lot in that opening statement, but it's just to give an overview of what people may or may not realize is going on behind the doors of a medical provider.
Right, and that's the thing. And also, I get a lot of calls. People say, well, you know, where's Dr. Adams? Or where's Phyllis? Or where's Dr. Sutton? You ought to have them on all the time. Well, guess what? They're at the hospital.
We're
You're
working.
on call right now, Dr. Adams. So I want to tell the public, if Dr. Adams just gets up and walks off the set, he's on call right now. So we do appreciate him, and hopefully we can get a lot of questions in before. So let's turn to Dr. Adams right now. The different characteristics of the original COVID-19 compared to the Delta strain. Can you give us that?
Sure. You know, whenever we had the initial outbreak of COVID at the beginning, the population that we saw in the hospital tended to be our elderly individuals, those with a high amount of comorbidities. They were our sicker patients. They were more susceptible, number one, to contracting the virus, but number two, they had a much harder time fighting off the virus with their own immune system. We see a different patient population now. The Delta variant, it doesn't care how old you are. We see children, we see adolescents, we see people in their 20s and 30s, on up to our elderly patients, the same as before, but that younger population is much more at risk. At the beginning, I saw very few individuals under about the age of, I would say, 60 years old in the critical care unit. As we speak today, half of our patients are in their 30s and 40s in critical care right now at the hospital. Our mean on the patients right now, as far as admissions are concerned, is 57 years old. It was much older than that with the first go around. As far as the symptoms that we see, it's still a respiratory illness. It still carries an increased risk of clotting, you know, and the other issues that go along with that, of course. But it's more about the patient population and the rapid transmissibility, right? This one is a whole lot more easily transmitted from one patient to the next individual as compared to the initial COVID outbreak that we saw at the beginning. With that being said, we take slightly different approaches. I say slightly, we take much different approaches to the way we care for these patients, both on the outpatient basis and the inpatient basis. From the inpatient perspective, we are less aggressive with placing these patients on ventilators, intubating them and placing them on ventilators. We try to use non-invasive ventilation much more than we did the first go around. Initially, when the outbreak started, we were looking at the data out of Europe. Those guys had been seeing it for a longer period of time than we had been seeing it here in the States. So what's the smart move? See what they did there, see what worked, see what didn't, and we will try to mimic those things, and hopefully we have good outcomes. As with any pandemic or any outbreak or anything that's new, those situations are fluid. Our therapies are going to change. The way we approach our patients is going to change. And unfortunately, some of the things that we do at the beginning may not be the best course of treatment for those patients for the best outcomes. So, like I said, we would progressively move from patients that required nasal cannula oxygen. Once they got to 6 liters nasal cannula, the data out of Europe said, hey, these patients are going to do poor. You need to go ahead and put them on the ventilator. That's what we did. We didn't utilize BiPAP. We didn't use high flow nasal cannula. We didn't use something called vapotherm. All of those things we thought had a higher chance of aerosolizing the virus and exposing the workers at the hospital, the doctors and nurses, what have you. And we thought, goodness gracious, we're all going to get sick with this. We'll be out and we can't actually care for the patients. So we followed what Europe did. Guess what? Not the best approach. What we do now is we take non-invasive approaches before we move on to intubating those patients and placing them on the ventilators. Don't get me wrong, some people will get to the point that they can't oxygenate their own blood with those non-invasive means, and they still require ventilation at that point. The medications that we had available, everything we saw at the beginning was that we don't need to use steroids. Anti-inflammatories are bad. Well, guess what? We use steroids now on the inpatient basis. We have the advent of remdesivir. That's a medication that we're using. It's an antiviral. We still are using other anti-inflammatories like the IL-6 inhibitor. That's kind of been in the background the entire time. On the outpatient basis, we don't have any great proven regimens for outpatients that have been through intense review by peer-reviewed journals, and we just don't have those studies. So whether you're talking about colchicine or ivermectin or Plaquenil or whatever the case may be, we don't have any data that shows that those things work. I'm going to come back to that in a moment. But what we do have is we have monoclonal antibody infusions. Regeneron is one of the common ones that we see. Those are designated for patients that are outpatient, that do not require inpatient admissions. Those are the people we're trying to prevent from going into the hospital. They've been diagnosed with COVID. They have a positive test. They have higher than normal risk factors for going into the hospital with the COVID infection, and we can provide those infusions and prevent some of those patients from ending up in the hospital.
Can I jump in, because you made a point about Regeneron,
Yeah.
and a lot of people saying they don't want the vaccine because it's not FDA approved.
That's correct.
But is Regeneron FDA approved?
Regeneron is not FDA approved either. A lot of the ways that we approach and treat this are slightly off-label, or they are not FDA approved. So we do see patients that are not vaccinated, and the reason they're not vaccinated is because they exactly as you said, they say, hey, this is not FDA approved, I don't want it. But yet when they become ill, they want to come to the hospital and get therapies that are also not FDA approved. But the situation changes as the patient becomes ill.
Yeah, and so there's stuff. And Phyllis, I got to ask you a tough question, because I've heard you speaking on it before. But I hear parents so many times telling me, well, Mark, my kid's not going to get sick. They're tough, they're strong. But some of the things I heard coming out of not only this hospital, but other hospitals, it stunned me. This is not discriminating, and it's not passing up the young kids. Can you maybe tell us a little bit and bring us into what the reality is with the young children?
Sure. They had something posted, or I heard, we were in our COVID task force meeting today, because we do meet pretty regular with our physicians and the team. We do have a team that handles these patients, so we can assure to stay as current and upbeat. Dr. Adams serves on that, along with several of our other point physicians. And what was brought up is, now what's out there is, this wasn't your daddy's COVID. It's hitting a younger population. It's much more young. And we're testing people, and that's the other challenge, is kids are getting it. Young people are getting it. Dr. Adams mentioned that the average age is 50, but remember, to get to 50, you had to have a lot of people younger. The people that were having currently that we're seeing that are intubated are definitely in their 30s. And we do have some that are getting tested that are much younger. And we've had, I ask every day, tell me the youngest person that we tested for the day that ended up coming back positive. And I can tell you in my report that I've gotten since this, we started, I mean, we were doing this before, but as of August 1st to today, so 10 days, right? We were seeing 20 patients. Today we're almost at 60. That's how quickly this is multiplying. The average age back then, I say average or youngest age, was 2 years, 4 months, 8 months, 20 months, 36 months, 16 months, 7 weeks, and we had a 2-week-old.
Holy
So
cow.
I was listening to Children's give their report, right before this, and when they said the amount of children that had it that are at Children's Hospital right now, and the age range are all under 2 years. That seemed a bit unnerving for me. It pulls at everyone's heartstrings. It definitely does. And they're at somewhat of a capacity model, so that becomes a challenge.
Unnerving is it's an appropriate word. It's a scary word. Are we talking about children that young getting sick? Or are we talking about them dying from this?
A lot of the children that we get within the organization, if they come through that are really sick, we transfer. And the challenging part for that is we recently transferred, again, I think it was around an 8-year-old or less. And what's scary for us is that they don't have bed capacity, and sometimes these transfers are limited to what we can send. Mm-hmm. And so when everything is great, we're able to get people to that other level of care. So some need hospitalization. Kids are historically resilient, very resilient, and they may do okay. But I tell you what, any parent knows that when their kid's sick, no matter how much or how not, and their oxygen levels are challenged, that's hard. It's hard to watching anybody that you got to put people on oxygen or medicine. So again, not to pull on emotional heartstrings, I guess what we're needing to say is that this is not just a disease of your parents or the elderly or people with comorbidities or other disease processes going on. What we're seeing today are people that were healthy, adults or kids, who the Delta variant determined that's it's contagious for them.
And Phyllis, I make a point that, and a lot of people are going to think, yeah, including myself, are pulling at heartstrings. No, I mean, these are the facts. And this variant has changed. We didn't deal with that in the first COVID-19 surge that came through. A lot of the part of a lot of the questions that I deal with, how do you tell if it's COVID or if it's Delta variant?
So just backing up a little bit, we're not here to pull heartstrings or scare anybody. I mean,
Right.
The data in and of itself is enough to convince individuals that,
No doubt.
hey, we have a problem. To your specific question about our traditional COVID versus the Delta variant, there are serology tests that can be run that can tell us exactly what subtype of coronavirus we are dealing with. Those are all send-outs. They take an extended period of time for the results to come back in. So it's not that we can put you in the bed at the hospital, run a test, and tell exactly what it is. With that being said, we know that we are seeing greater than 85% Delta variant at this point in time. So anybody that we're seeing now, the assumption is just that, hey, we have the Delta variant. The reality to that is that it really doesn't matter which type of COVID we're dealing with. We're going to treat you by the symptoms that you have and the severity of illness that we're dealing with while you're an inpatient in the hospital. So I'm sure in the future, as other variants come out, we will see a different dominant type, at which point in time we'll say, okay, we are going to say we think it's this variant before we have the test to say that it is indeed that particular subtype.
Let me ask you this, just a follow-up on that different question though. For people who have already had COVID, do they or why would they need a vaccine?
So the group that is the least studied group, I'm comparing individuals that have been vaccinated, the individuals who have not been vaccinated, and then the individuals that have had COVID. Of those three groups, the individuals that have had COVID is the least studied group. Okay. With that being said, The data that comes out of Israel is the best data we have on individuals that have previously had COVID and received vaccination. Those individuals have a 20-fold greater increase in antibody production than those individuals that have either had COVID and developed natural antibodies or have had the vaccination alone. What we know is that the vaccination provides better coverage for the various mutations as compared to the natural acquired immunity from having had COVID previously. And the reason for that is this. Whenever we contract COVID from the community, I had COVID in November, okay? I was vaccinated several months later, so I'm in this group that's done both. Your body is exposed to the virus. It develops two types of antibodies. Actually, two parts of the virus it develops antibodies to, and there are two types of immunoglobulin to each of those, all right? Okay. That may be a little.
I'll try to follow you.
That may be a little beyond the scope of what we're talking about. But long story short is that your body is going to respond to multiple parts of the actual virus itself. The immune response that I have, the immune response you would have if you were infected with it, the immune response that Dr. Bobby had, they're all a little bit different based on the virus that we saw. I may have a more robust immune response than you do. Bobby may have a more robust immune response than I do. What we do know is that when we utilize the vaccine, it is specific to the spike protein, and it causes a much larger immune response than it does to natural acquired immunity from an infection. Okay, so it's variable for those individuals that got infected as compared to those individuals that received vaccination. As it stands now, we don't routinely test our antibodies to see what levels we're at. We would call that a quantitative test, meaning what's the number of antibodies that we have per given volume of blood. There are tests that are available for those things. They're not routinely utilized in practice, although I think they probably will be in the future as we move forward to determine which individuals have appropriate antibody titer levels as opposed to those whose immunity has faded and is approaching zero, and those may be the people that we would expect a greater chance of reinfection, or they may need a booster, something along those lines. We don't have that data in place yet. I think that's going to come down the pipe in the next 6 months to a year, though.
So let me ask you, is it fair to say, and maybe y'all are, I'm not sure, but do y'all even have time to do all these tests right now? Y'all trying to keep a hospital run, or is that part of the strategy?
Well, the utility in the acute setting is limited. There's no benefit to knowing what the antibody levels are for the individuals that are sick, admitted to the hospital, or in critical care. This would be something that we would want to test for on an outpatient basis in somebody that's not sick. This is a preventative strategy that we may need to utilize in the future. But like I said, it's not something that's being recommended or done routinely as we stand today. The recommendations for boosters, we do not have that information as it stands now today. You can make an argument that future exposure to COVID that doesn't lead to clinical infection could serve as a booster in and of itself. And that's an opinion. I don't have any data to support that particular statement. That's just the way I interpret immunology and the way I would expect things to move. So preventative strategy, no utility in the acute setting for the really sick patients that are in the hospital.
Let me ask you something. I want to ask a question, but I want to sort of get the numbers first to make sure that the audience hears the age groups that are currently in critical care. Let's maybe break it down. What's the youngest age group would you say is in critical care?
We've had individuals in their 20s in the critical care unit. Right now, we have 3 individuals that are in their 30s, several people in their 40s, early 50s, and then we have several patients in their 60s and one patient in their 70s. That's right now today. That number changes consistently, but we have seen healthy 30-year-old patients come into the hospital with COVID and end up in a critical care unit on the ventilator.
Okay,
we did not see that on the first go around. Maybe a rare exception that, we might have seen 1 or 2 people like that.
Right.
But now it's common.
So my follow-up to that would be, and it's a very key question, and I want everybody to really listen to the answer here, because I don't know it, but I'm about to hear. How many of those you just mentioned were vaccinated or unvaccinated?
None of those patients in our critical care unit have received the vaccine.
Okay.
I do not know that during the duration of this particular phase of the pandemic that we have actually had a single patient in our critical care unit that has been vaccinated. I will tell you this, of all the individuals that are admitted to the hospital, greater than 90% of the people that are admitted to the hospital with COVID diagnosis are unvaccinated. So there's a small subset, slightly less than 10%, that have received vaccines and came into the hospital. Those patients do not end up in critical care. Those patients go home much sooner and have a much less severe course of disease. And that holds true in the community. I'm just talking about what the hospital numbers are. But if you acquire COVID as somebody who has been vaccinated in the community, your course of illness is going to be much milder than the individual who has not been vaccinated. And somebody that had previously had COVID and has antibodies, appropriate levels of antibodies to help fight this off, they're going to have a much less severe course. If you've had them both, you may not know you have it.
All right, and Phyllis and Dr. Ben, of course, I've been in the ICU unit before. We've done many segments from the medical center. But if I were to walk in today, what would it look like?
So the appearance of the ICU right now, while we're dealing with the COVID pandemic, is different than you would have seen prior to the pandemic. Every room that's in our critical care unit has been made into a negative pressure room. What that means is that the pressure inside the room is lower than the pressure that is outside the room. Therefore, anytime you open a door, it allows air to be sucked from the outside world into the room with the patient and expelled to the outside environment. The reason we do that is so that we're not pushing viral particles from in the patient's room outside to expose the other healthcare workers and the other patients. So those are negative pressure rooms. We have a great team of guys that did some engineering. Kevin Girardi and his team put those negative pressure setups into those individual rooms on very short notice, and we've utilized those extensively. One of the other things that we do is we try to minimize the amount of time that the staff is in the room taking care of the patients. Historically, you'd walk into a critical care room and the patient would be in the bed. If they were on the ventilator, you'd see a breathing tube connected to a circuit, which is tubing that carries the oxygen from the ventilator to the patient, and that would all be set up right by the patient's side. Well, we now have the ventilators outside of the room, very long circuits, or our tubing that's used from the ventilator to the patient, that it runs all the way to the patient. You know, it might be 8 or 10 feet. The IV pumps that used to sit at the bedside with very short sections of tubing that took the medications and fluids from the pumps to the patient, we have those outside the room with multiple extensions. The carts that the nurses would utilize for their basic supplies, ranging from alcohol swabs, syringes, needles, whatever the case may be, those are no longer in the patient's rooms. Those are outside in the hall. So when you walk into the ICU and look at the COVID section, outside of every room, you're going to see a bank of IV pumps with tubing running into the room. You're going to see a ventilator with tubing running into the room. You're going to see the cart that the nurses utilize on a regular basis outside of the room. Every time you open the door and go into that room, you have on maximal protective gear, you have on your N95 mask, you're going to have on eye protection, you're going to have a head cover on, you're going to have on a gown as well. When you go in, you have to be careful because now we have all this tubing that's going from outside the room to inside the room with the patient that we have to step over. I believe you'll have some graphics that'll show those pictures, and that's what those pictures are representing, is the way things look in our critical care unit now as opposed to what they did 2 years ago when we didn't have to do this kind of stuff.
So Phyllis, it's just a lot of high-tech stuff, isn't it?
It is. And, you know, somebody mentioned to me that they spoke at Rotary recently, which was a good idea. Of course, we're trying to outreach and get the education. But they got somebody to volunteer to be a day in the life, and they put on the gown and the garb and everything that we stay in, they stay in all day long, right? All day long, just to sit through the presentation. Well, I have to say, at the conclusion of a 30-minute presentation, they were hot, they were sweaty, they were itchy, they wanted to take it off, they didn't. Welcome to a day in the life. And I think that visual, that's why some of these pictures may help, lends itself to say, this isn't like we're just walking in like we're dressed today. Is our staff are in this all the time. And it's just an interesting dynamic and difficult scenario. They may wear, and we need to bring some of that maybe next time, you know, the mask that has, it's a rebreather mask and respirator, and a lot of different things that we have. The other stuff is, we're talking about critical care. We've got, again, I always say that we got a good team, and again, I reiterate, we got great medical staff members, but we have a hospitalist group that they see the majority of the patients that are in the hospital. And so we still have our primary care docs who will come, and of course our specialists. But in our intensive care unit, we have intensivists that will be in that unit at all times, the majority of the times, to see patients. And that way, if you have a problem, they're on site, immediately accessible. Dr. Adams and his team are in the hospital at pretty much all times. We always have that. Not a lot of places do. And so if you do start to have challenges or go bad, the great part is we've got the talent there for you. The emotional part is your family can't be with you. If you have COVID and you're in the unit, they can't. But our staff is wonderful about FaceTiming and putting people on iPads and being able to communicate with family members in a different way. And that's hard too. That's very difficult, and it doesn't satisfy the person on the other end, but it still is nice to be able to see your loved one in a compromised way while we're still protecting them.
Let me add one more little question on this. The mask is still the best bet, the N95, hands down?
Hands down.
Okay.
Hands down. There's some data that suggests some component of the transmittability or transmissibility of the virus is aerosol. In the aerosol environment, the N95 wins hands down. As we have virus transmitted by droplets, our masks that are not quite as substantial, they provide benefit in that scenario. But yeah, the N95 is still the winner.
So is this both particle related and aerosolized, in your opinion?
Yes.
Okay.
But if you can't have an N95, a mask is good. It just, and I know some people feel cloth masks, if you're a medical personnel, we wear the medical ones on the unit. But a cloth mask doesn't always do all that an N95 or a surgical mask will do, but it does give you some layer of, if you sneeze, it gives you some level of protection. And I know some people debate, should I wear a mask at all if it's a cloth one? Well, I think our last flu season, we didn't see any flu. Not everybody was walking around with a surgical mask, right? It did something. No, it's not as great as an N95 or a surgical mask or some of those others, but it still keeps you to you, your spit to yourself.
Constantly going around like this.
Right.
But is the flu back, by the way?
We have not seen very many cases of the flu.
I get that every day.
The
flu's dead. The flu's gone.
It's not. It's just not at the party right now.
Right. Our
thank God.
Our excessive hand washing, utilization of our alcohol-based, hand scrubs, wearing the mask, maintaining our distance. Guess what? It's not just COVID. It's every other infectious disease that we're seeing a reduction in because of the steps that we're taking for COVID.
Right.
And so that's why we haven't seen the volume of flu that historically we've seen.
I think you said over 35 of your staff is out with COVID. Man, that's incredible when you're already tired. You already have been through a year and a half of fighting a monster, and then you get the variant comes in and it's more contagious. And first of all, kudos to all the healthcare workers who are fighting through it, but logistically, when you look at this from let's just separate the compassionate side with the business side, it's gotta wreak some havoc on you.
I have to say, our staff and our medical personnel and everybody who's dedicated their life to taking care of other people just in general, and it's not, look, that's everybody in an organization, from our housekeeping department to our maintenance crews to everybody has touched the patient, whether they realize it or not, and their dedication and their commitment strong. Are they tired? Absolutely. Are they giving up a lot in their own life for this? Absolutely. But what people don't realize is we have negative pressure rooms. Every time you're a COVID patient, we're going to put you in a negative pressure rooms. We had taken a lot of that down. I mean, the positivity rate was less than 3%. We're back up to 33%. That happened in a 15-day window. Probably it was about 15 days, you think, Dr. Adams?
That's about right.
About a 15-day window. I mean, we were okay, and then the weekend came, and all of a sudden we start seeing an uptick of 4 patients, 6 patients, 10 patients, 20 patients. We're like, what in the world is going on? And they were all getting hospitalized, and they were getting challenged, and it was quite evident we had to gear up for what could come. And so our staff, though, always come to the challenge. They're amazing. But it's more difficult this time, I think, than the first time, only because we have people that are going out too. They're young. and they're young. And so what'll happen is that they're out for a period of time, and so people are working with skeleton crews. People are working with challenging times. We're waiting for people to come off of being sick. But if you've ever had COVID, you recognize the day you come back, you're not up to par. You're just not infectious, right? But you're tired and you're winded, and so here we are bringing people into that. School started this week. We try and partner with all of our local schools for protection and help them as the mandates come across. But I have to be honest, my concern is that you are putting people in an environment that may or may not cause another large percentage of people who will be exposed to something. Maybe not, but as a healthcare organization, my job is to plan the what if. What if it does? What if we start to see a bigger surge? What resources do I have and what resources do I need? So, to Dr. Adams' point, we don't play the Pollyanna and we don't play the woes and no's. We have to be prepared for what if it does come? What if this isn't the peak? And everything that we've learned or hearing from our statewide initiatives is that we haven't really, I kind of do base camp 1, we haven't hit all of that yet. We're still at base camp 1 because the positivity rate, and I showed you the graph, continues to go straight up. It is not flattening. It is not stopping. It is not having a couple of days that are, these were calm days. Every day we see more patient coming in than we're able to discharge out.
So we're still, just officially, we're still in a pretty good pandemic.
Oh, yes.
Yeah.
And even at the governor level, we are not, and there's not a date or thought in sight that this is slowing down right now for us.
Okay. Let me ask you, and the one thing I admire about both of you is from the first show we did, y'all used the word fluid quite a bit. And y'all never put your feet in concrete where you said, this is the only way we're going to treat it. Y'all been fluid. And y'all have also admitted some things worked, some things didn't work so well. From COVID, the original COVID, to now, what are the things that have really held true that you can go in and say, we're doing this because this worked? And you sort of touched on it a little bit earlier.
Yeah, the things that we see that tend to work the best is utilization of steroids for inpatients with oxygen requirements. These are the patients that are sick enough to be in the hospital and they're not maintaining their oxygen saturations where they should be. Steroids in that group works. Remdesivir appears to shorten length of stay and decrease mortality, at least in the short term. Good supportive care. We take care of the organ systems that are problematic. Good critical care. Those are the things that are always going to hold true. And the reason I stress about steroids being utilized in the inpatient population is because the data for utilization of steroids in the outpatient population is poor. It does not help. It does not prevent admission to the hospital, but what it does do is it depresses the immune system's ability to fight this virus in the early stages, and also increases viral shedding. Surprise, surprise, increased viral shedding equals more likelihood of people around you contracting the illness. I get on Facebook, social media, just like everybody else does, and I read these wild recommendations for this outpatient regimen that's going to prevent your patients from ending up in the hospital. Well, let's think about it. 99% of the individuals that get COVID are not going to end up in the hospital. It's a large numbers game. We have about 120,000 people in Terrebonne Parish. If 1% of that group needs to come and get in the hospital, that's 1,200. Let's say it's half of that. That's 600. We can't handle 600 sick COVID patients that require inpatient admission. So back to the point I'm making is that regardless of what type of protocol you put together for outpatient medications, the large majority of those patients weren't coming to the hospital anyhow. I could write Flintstone vitamin prescriptions for everybody that I ever saw with COVID, and surprise, surprise, 99% of them don't end up in the hospital. So these claims that you continue to see from individuals with a set of credentials, apparently, that seem to have trained at a medical program somewhere, make wild claims to these things that there is absolutely no data that shows proven benefit. And there's a huge bias. Individuals in the community, they want to agree with what they think is right, regardless of what the data says. So, every time I look at medical literature, I look at it with a very skeptical eye. I want to read that information and determine, hey, what are the flaws in this study? Where are the weaknesses? I want to see good information from peer-reviewed journals to where I know that the decisions I'm making are appropriate and well-rooted in science. Because at the end of the day, actual science doesn't care about your feelings. There's no component that has to do anything with your political views, what your feelings may be about a given situation. The science is the science, the data is the data. And unfortunately, the large majority of individuals that look at these posts on social media, they don't have the wherewithal to evaluate those journal articles with that degree of skepticism. And so they're going to say, hey, look, my brother, sister, uncle, somebody I trust said X, Y, or Z is the way to go about this. The reality is, in the outpatient setting, none of that's factual, none of that's true, none of that's been proven. Now, 5 years from now, when we look back at this, we may say, hey, this subgroup looked like they might have did okay. All right, there's no magic vitamins, there's no magic pill to take. The only group that we know that we can do something for and have good data on is the monoclonal antibody infusions, which those studies have their weaknesses for the outpatients, and what we're doing for our inpatients.
Well, let me ask you this, with the, if I heard you correctly, let's say less than 1/2% are sick enough to be hospitalized and they become really sick. And is this, well, I know you'll probably say they might have had some pre-existing conditions, but does the viral load they get have anything to do with it? Because a lot of people always said if somebody sneezes right in your face, you get a bigger viral load than if you walk in a supermarket and go past someone who was there 5 minutes ago. Any difference?
I have a hard time answering that one. I don't have any direct data to quantify viral load with the severity of illness that we will see. Right? I think the bigger factor is that if you have an exposure and you have an immune system that doesn't have the ability to deal with that viral exposure, that individual is much more likely to become clinically ill than the individual that has the immune system to fight that off, whether that's through naturally acquired immunity or previous vaccination. But as far as the viral load exposure and the clinical severity of illness, I can't correlate that. I would assume that based on a higher viral load, the expectation for you to become ill and actually contract the virus and see clinical illness, that the higher viral load would probably show that, but I don't have any data to back that up whatsoever.
You know, I was sort of joking.
And there may be data out there that I'm unaware of.
Right.
So
I was sort of joking this morning with somebody. I said, what the hell ever happened to penicillin? Ever hear about?
We would like some bacteria to treat at this point in time.
Yeah.
Virus is a different animal.
Different animal altogether. And Phyllis, just breaking down, you're the CEO of a major institution. And normally that means taking care of that institution. But right now, it's the institution married to the community feeding the institution. What do you need as a CEO from this community?
That's a good question, Martin. I mean, our goal is twofold. One is, we could get into the political debate, but we're staying out of that. This is medicine. This is what we do. There are people who believe in the vaccine, people who don't. You're not going to win that conversation because those that have strong beliefs. But in the end, what our goal is, stay out the hospital. What can we do to keep you out the hospital? We are taxed in the volumes that we're seeing. And even if it's a small percentage in the major scheme of things, the amount of people that do come in want us to be available to them because they're sick. If you have had the vaccine, then your ability to get better faster and use less resources is absolutely proven. If you wear a mask so that you don't transmit or get the disease or viral load at a stronger level, it is helpful. If you're able to wash your hands and do all the things that you did before, it's helpful. But our role is twofold, is to take care of you when you're really sick, but also try and help prevent where you're going. So we built the testing center that's right across from our ER when we were in COVID, as you called it, COVID original. And so you're able to drive through. We did over 25,000 vaccines for our community at the definitely at the at the Civic Center. We went ahead and built a drive-through testing and COVID center, anticipating there would be something else. And so you can go, you can see up there on the monitor the number, 873-4686, and you're able to go ahead and get the COVID vaccine. It's free. It's free. And we are able to give, we've been giving over 100 a day. And that's good. Somebody's paying attention, you know, so that part's good. From our testing, well, yeah, it's close to 100 a day. I want to make sure I'm saying that right. Our test, which we also are able to do, we used to do, I guess, around 100 or more. We are up to 180 a day. Now, we're able to be open because some of the things we recognize, we used to be open about 8 to 4 because, again, we've got some staff challenges, but that doesn't minimize our expectation. We're going to do what we have to do to meet the needs of the community. And we are looking next week, we'll be open Tuesday, Wednesday, Thursday, Friday, and Saturday. Because the more people I can get to either be tested to know they have COVID as quick as possible, because whether you come to us or any place else that does testing, you need to know whether you do or don't have it so you don't go to the grocery store and get all your supplies for what you may have to quarantine, because you've just spread a whole lot of love to people that may not need it, right? So we're going to do on Wednesdays like 10 to 7 p.m. so people after work. The other thing we invested in that I have to say I'm real proud of my staff and my leaders who as we work through this is that you used to have to send out all your testing and people would find their results in 3 days. And do you remember at the beginning of the first one, it was all about testing and the challenge. You couldn't get tests. It minimized Dr. Adams being able to do some surgeries. It minimized several things like that. We spent well over $1 million to invest in something that will give us those test results within 2 hours. So we're able to run our own, test it, and then go ahead and give it back to you or the information back to you. Now, I'm not saying that if you're on TV and you're listening and you say, well, they gave it to me in 3, we got to batch some of them and run them. But we have it on site where we can do that. The other unique thing is we use ultraviolet light to make sure that we get the infection out of each and every room, but it's built into the air duct system. So the patients don't even recognize some of that. We're able to clean the rooms and sterilize the rooms to a degree to help foster that they won't get subsequent infection from that. So there's a lot of things we've done to try and help and to minimize some of this as we move forward. But again, our role is just to make sure, please, you know, there's so much, and like I said, we're not unique. We're helping the other hospitals, several of them in the area, that we're the higher level of care and they need to transfer in. We did take some from some of our colleagues that were a little further down the Bayou who needed some assistance. They're seeing high acuity COVID patients. They may not have had enough supplies on ventilators. We're helping. Our docs are helping do, as Dr. Adams is saying, is do like a Q&A session on what we've seen that works that maybe will help them because they're having to hold patients more. The other challenge that people don't realize is, you know, again, as we're challenged to be able to take their patients, other places are challenged to be able to take ours. And so everybody's kind of backlogged because, again, the influx is much higher than the discharge rate. And until we stabilize out a little bit, it's getting to be a little bit overrun.
Can I ask you this, because we've heard so much about, you know, when it comes to the vaccine, the most populace I've heard from are the mothers who are able to have children at childbearing age. And they're pretty steadfast with the vaccine. But I want to sort of go further than that. Are you seeing that the COVID causes miscarriages in women? And then the second part of that question, if you could answer it, does the actual vaccine, if a mother decides to get it while she's pregnant, does it transfer to the unborn baby?
Okay, I'm going to add a little bit to this answer. I had a question today from an individual that works at the hospital that is of childbearing age, and the question was whether or not these mRNA vaccines can cause infertility. And there is no data whatsoever with any of the mRNA vaccines associated with COVID that shows any amount of infertility or sterility that's caused by these vaccines. That rumor started simply through discussions on social media and was perpetuated across the board. Zero data on that whatsoever. Okay, so that's the first myth to dispel. The next thing, I have seen several pregnant ladies that have come into the hospital, COVID positive, actually sick, respiratory symptoms, febrile, things of that nature, that have had miscarriages. In discussions with my obstetric colleagues, they have also seen the same thing. Now, of course, the patients that I see were brought into the hospital by the obstetricians. I was just asked to place an epidural or take care of them for whatever was necessary, right? So we have seen some of those scenarios. Now, we know that our COVID patients throughout the hospital, they have an increased risk for thrombosis, forming clots. So this is a proposed mechanism just through our discussions, is that there's a chance that the coronavirus can create a prothrombotic environment which clots can form that can affect the placenta, and as such, blood flow to that baby. So I don't have definitive data on that. That is just discussions between myself and other physicians on staff. So
Yeah, but it's just fact. You've seen it.
This is observation,
Right,
right?
yeah.
Anecdotes. These are the things that we have seen. Multiple
Right.
anecdotes do not equal data, but it is observational.
Right.
Okay, so yes, we have seen it. As far as vaccination and a pregnant woman, so when we administer a vaccine to any person, that vaccine will generate an immune response, and there are several types of antibodies that are formed. There's IgG and IgM. IgG in particular is the one that we're interested in our pregnant women. When that antibody is formed to the spike protein in the case of these vaccinations, that IgG antibody has the ability to cross the placenta. And so it can cross the placenta and actually get to the unborn baby and provide antibodies for that baby in a form of immunity for COVID. So we talked about some of these newborns that we have tested that were positive for coronavirus. Had those mothers received the vaccine, the likelihood of those children contracting this illness would be much, much lower, because they would have IgG antibody available to them because of the mother's decision to be vaccinated. So there's a big benefit in that group. Now, just like with any other medicine that we have ever studied over the history of time, which group of patients do we do the minimal amount of research in? It's our pregnant women, right? But we have enough pregnant women out here that we show that there's a very low risk for receiving the virus, especially when not receiving the virus, receiving the vaccine. I misspoke there. As compared to individuals that contracted the virus. We know all the bad stuff that happens with the virus. The vaccine, tiny risk.
Yeah, I would think. This may be a crazy question, but I'm just a TV guy, so I ask it anyway. But when we had the crack epidemic, pregnant mamas, the babies were getting addicted to crack. Is that a similar way that just the body in a pregnant woman transfers whatever's going in your body to that unborn baby?
So there's a couple of steps that are involved for anything to go from the mom into the baby. It depends on the size of the molecule. It depends on what the particular molecules are made from and how easily they can go across the various membranes that are there. So we know that narcotics are very lipophilic. Cocaine, crack in particular, is not a narcotic. It's actually a local anesthetic. But we do know that those components can indeed cross as well. So a mom that's a heroin user, those babies are going to come out and they will be addicted to heroin because their receptor sites for the opiates have been constantly being bombarded when the mom was using. So there's a number of things that cross the placenta, whether that's ranging from things that we eat, things that we drink, medications that we take, and then there's some things that can't cross. But there's a number of reasons that those things occur. But in the case of the COVID vaccine, the IgG readily can cross to the baby, to the fetus.
So Phyllis, now we're getting to a point. I've had the parish presidents on many times. Of course, I want to stress the parish presidents rely on you in the hospital to give them the medical information that they normally regurgitate to me when we have them on the air. With this peak. Spike is too little of a word. Pretty soon, if this continues like this, are we even close to herd immunity, or is that just a word that's being thrown around that we're not even close to yet?
Oh, Martin, I can't tell you we're at herd immunity. You know, I guess if we'd be there, we'd start to see something different, right?
Right.
And we're not seeing that. And it's a different variant. And so I'll let Dr. Adams, because right behind Delta, see, I said I was going to give it to you. Hang on. There's
Is
Gamma.
yeah.
There's
yeah.
a next one, or
Yeah.
Lambda, and
Lambda,
then
yeah.
there's Gamma. And so we're not seeing that value throughout the state yet. And you're going to see other states. This will travel. The reason why you're seeing it more in Louisiana than you're seeing it right now in some other states is our vaccination rate's so low. And so people are more susceptible to getting it. And as Dr. Adams said, we have either people that didn't have COVID or didn't have the vaccine, but a lot of the people that we're getting had neither. And you are prime and open to the opportunity to get the virus. It likes that as a host.
Right.
And so 90% of the people we're seeing never had COVID and never had the vaccine.
Right. It's there was a discussion today in a meeting that I was in prior to coming here. Our total infection rate for the parish throughout the entire duration of COVID, all the way from the beginning till now, we've had about 10 to 12,000 people that have been sick with COVID. Roughly 10% of the population of Terrebonne Parish. We have about 30% of the parish that has been vaccinated. That's only about 40%. Now, depending on who you believe, who you read, where does herd immunity occur? 60 to 80%. That's the low end of the numbers that I read. So we're not even halfway there from that perspective. So, herd immunity, as far as viruses are concerned, I cannot give you a single virus in the history of virology that has ever reached herd immunity just from naturally acquired immunity from contracting the virus without the assistance of vaccination. So we've got a long way to go before we even consider that as a viable option.
Right. And I guess, Phyllis, looking at you for the many years you've been, and I'm going to say and we'll excuse Doc, because I know he's getting an important phone call. But and I know you're going to deflect that you're not the face of the medical center because there's so many people that are there with you, but as the CEO, I'm just trying to find, because in everything we've ever covered here in HTV, we've never covered a pandemic that has just wave after wave after wave. And at the same time, we're trying to keep the public positive, trying to keep them from panicking. But on the other flip side, we got to be completely honest with them too. So how do we marry the two?
I think honesty. We're always very upfront. I'm more than willing to have a conversation to the level that we know. I always bring in resident experts. I've been doing this, 19 years, almost 20, here at the hospital and as the CEO. But we have a lot of good other people who are the resident experts who do this all the time. And so where I can have conversations in the public, and our job is to help the public understand. I'm not going to convince everybody, but I know we had a conversation last night at the parish council. And the reason why I say that is we volunteered to say maybe we can help give you some information. But if something came out of that and 5 people got vaccinated, or they took precautions, or they don't come into the hospital, we accomplished something. If they watch TV in the morning, I'll have TV on. I'm not really a big TV watcher. We're just so busy, right? But I hear the New Orleans report and the Baton Rouge report. If now you pay a little extra attention to say, well, now I can put that in context. Or maybe that is true what they're saying. You can watch, because they're a mirror hospital of St. Tammany over in Covington. And we always very much prided ourselves of very good collegial relationships. We have great relationships with all of our CEOs throughout the state, but they're a hospital service district. And when you see their doctors say, I don't know what to do next, we're at capacity, we're past capacity. When we hear some of our other hospitals saying they're triaging in the parking lot, they're further in this process than we are right now. And I tell my staff, be prepared for more. As much as you're doing and you're tired, I appreciate it, but be prepared for more. And people keep stepping up. But again, we have to take the initiative to try and keep some people out And if that's educating or taking the time or being the face or bringing in the Dr. Adams and the Dr. Suttons and the Dr. McKees or any physicians that we can help educate their patients and our community, that's our responsibility. That is our responsibility. We appreciate you relying on us for when you need care. Today I'm saying, please don't come. Just don't come.
Right.
You know. But if you're sick, please come, of course. But we've tried to have venues, instead of using our ER as a testing center, you can go across the street. That your primary care provider, if you need vaccines, we will try and help. If you need some information or something we can provide in the school systems, we've partnered with all of our local school systems. You'll see that we have a partnership banner outside of all of our parochial, in addition to our public schools, and we're talking to all those superintendents of schools. And we have, you can call in. And if the teachers have a question, because this is what they're seeing in their classroom, they can ask a nurse. We'll ask a doc. We're lending our physicians out, and they've been gracious enough to be very participatory. If there's anybody who are seeing things that we might have seen in greater volume, that they'll help educate or give. I don't know, I don't want to say I don't know what else we can do. We're willing to do anything. And our docs and our staff are too. I've never asked them to do anything that they haven't said, sure, I want to be part of the solution. They want it gone as much as everybody, you know, so we're willing to help.
And they've been incredible and transparent. I want to ask, and maybe we'll get Dr. Ben on again, and we'll start wrapping it up because I know y'all very busy. You made a good point, and it sort of put a question in my head, Phyllis, that if somebody's they might be having a summer cold, but they're scared because summer colds can be COVID, but they may have a summer cold. They walk into the emergency room to get tested. Somebody right next to them have just walked in, has COVID. So not only a summer cold now, they might have COVID. I'm sure is that what you're talking about, divert across or something like that?
Yeah, I know that there might have been on one of your shows somebody advocate that go to the ER if you're scared. I'm going to tell you, no.
Right.
Go to your primary care provider. They're good. They're our face in the community. They will see you. They can do televisits. They can do a lot of things. Or by a doctor's order, you can go and get a test. Now, people wonder, why do I need a doctor's order to get my test? And maybe I can take a second to go through that. Because once we test you, I say you, anybody,
Right.
then it will go to that primary care provider so he can follow up with you. And to Dr. Adams' point, if you are positive, then we can go and get you the IV infusion that keeps you out the hospital. I'll never say them very well, the monoclonal antibodies, right? That we can get you. And so if you go to maybe one of the pharmacies, which I'm not advocating not to, but we were having this discussion I was having with a group of physicians today, they give you the thing, but it's handed to the patient. Because I asked, why aren't we having this major amount of people coming for the infusions? Because they may be positive and they go home. And so it's not sent to their provider, it's handed to the patient. Mm-hmm. And so that's good, but then what? So then they wait till they maybe have a couple of things. They might go on Facebook and get the treatment of the day, and then they might do worse. So rely on your community physicians who are very versed in knowing how to care for this particular initiative on a community-based, disease process. And so that's kind of some of the things that we're hoping will happen.
And I want to be fair as we close, because we come on and we interview a lot of people, and we get a lot of different. Everybody's got an idea. Everybody's got a thought process. But what would you like the public to know? Any information that we put out that you say, I don't know if that was completely correct. And it's not malice, but everybody has a different idea. What do you want the public to know that would sort of ease the burden on you all, because it might have been misrepresented? Anything out there?
So one of the things that I commonly see on social media is the misrepresentation of the data that is in our VAERS database. That is the database in which we keep track of reactions that may have happened to vaccinations. The information that goes in those databases is information that is put there by the community, by the patients themselves. It is not an overly scientific database. It is just a collection of information. For instance, we know that billions of injections of these vaccines have happened worldwide. We're well over 100 million here in the United States. If you look at the information from the VAERS database posted on the CDC website, it will show that X number of vaccinations were given, X number of deaths occurred. Those deaths are all-cause mortality, meaning that I had the vaccine today, yesterday I got shot in a robbery, the patient's dead. It goes into that database as long as it's reported.
Wow.
You get into a car accident, you get killed. You have a pulmonary embolism and you die. All of those are included in that subgroup.
So skewed.
Well, it's that the data is all-cause mortality, and it clearly says that. But you will see that information perpetuated on social media as, hey, this vaccine caused this. If you continue to read the same data set, it will show that the information as analyzed in review of autopsy reports and medical records shows no causality between receiving the vaccine and those results. Myocarditis, that's another one that I constantly hear about. Inflammation of the heart and the heart muscle itself after the vaccination. Same thing, reported. Is it because of the vaccination, or were these people going to end up with myocarditis for other reasons? Is it in a greater incidence than the normal community would have seen myocarditis from other infectious causes? We know for sure that we have myocarditis and other cardiovascular effects from the virus itself. So whenever you compare the incidence of these events, whether they are indeed related to the vaccine or totally unrelated, and the things that actually maybe because vaccine effect compared to the effects of having caught COVID and dealt with these repercussions, the risk-benefit factors heavily weigh in favor of receiving the vaccine as opposed to not. That is data that is indisputable, and that is straight from the science. Now, there's individuals in the community may still choose to say, hey, I don't want the vaccine. We don't know what the long-term effects are. It's not FDA approved. That's fine. But your choices may indeed place you in a much worse position moving forward than having received the vaccine. There's some information that I've been seeing that does suggest that we will see FDA approval of this vaccine in the next 6 months, though. But that's future, so you can't quote that as
Right.
cut in stone, but that's where we're headed.
I'm hearing the same thing.
Yeah.
Phyllis, I'd like to give you the floor for the last word.
I just, again, want to, number one, try and educate the community, is just, as Dr. Adams said, rethink what you read and see and have, to ask the right questions, because we want to protect you, and that's really our goal. The other thing is, I think if you see a healthcare worker, gosh, say thanks. And people aren't doing it for the thanks, but this has been a long haul. It's been a long time. And people are saying, maybe I don't want to do it again. As much as the community thinks they don't want to do it again, some of those healthcare workers, and when I say healthcare workers, I mean all that provide care within a healthcare facility or a doctor's office or whatever, and saying, maybe I'll go ahead and retire now. Maybe it's time for me to sit back now. Maybe I'll come back later, because they too are mentally and physically drained for what we're seeing. It's hard to see, people go through this kind of disease process that's so consistent. And, but we're going to do it. And the pride I have, and I'm humbled to be in this role for so long, to work with some great people, and who never, ever, ever say no. They don't. Now, they don't always say sure with a smile, except of course maybe Dr. Adams or something, but not always. Right. But the thing is that they never say, no, I can't or I won't. And I have to tell you, in my entire career, I've not gotten that, not here.
Well, I want to close by saying thank you, because every time I've called y'all to come on, and I want to stress this to the public, and I want to put this in different categories: government, medical services, people. What Dr. Fauci and others do, and everything that people get involved in those conversations, really I separate that from the Terrebonnes, the Thibodeaux, and all that, because we see y'all all the time. Y'all on the ground running. We talk to y'all. We see the hours that y'all putting in and the stress that y'all are going through. And never have I called y'all and y'all not Never has Phyllis or Dr. Ben ever said, "What you gonna ask me?" And I just sort of throw the questions out, and if you can answer it, you do. If you can't, you'll go research it or do whatever you can. So the transparency's there because it's so fluid. We may be on 2 weeks from now talking about another variant that's acting different than the Delta variant. So I just want the public take a deep breath. Just like Phyllis said, when you see a healthcare worker, give them a little fist bump or thumbs up or whatever it takes to keep them going. Because a year and a half ago, we asked them to save our lives, and they're still trying desperately to save our lives. So thank you very much for what you do. We appreciate it.
Thank you.
All right. There you have it. Dr. Ben Adams, Ms. Phyllis Peoples, Terrebonne General Medical Center. We'll take a break. A lot more. Don't go away.